We'll move to our third speaker for this session, who is going to cover a very nice topic also. It's about membranous glomerulonephritis, what is new. She finished her fellowship in nephrology from University of Toronto in 2022, and when she came back, she became a consultant nephrologist at Sahar Hospital.
So, good morning, everybody. Good morning, everybody. Thank you for the introductions. Today, I'm going to present about a talk in GN that have so many advances in knowledge in the past 2 decades. To my knowledge, I didn't know that if any other GN disease have such huge discoveries in a very short period of time. So, in my outline, I'm going to present briefly about the natural history about the disease, mainly discuss about the recently discovered antigens in diagnosis and treatments of membranous nephropathy, discuss briefly about changes in the clinical guideline based on this evidence, and the role of anti-PLA in management of membranous nephropathy. So, membranous nephropathy is the most common cause of nephrotic syndrome in adults, as all you know, more common in male, predominance on white, and rarely in children. And membranous nephropathy has been known as the disease with 1/3 rule. Membranous nephropathy, the name came from the histopathological changes in the kidney biopsy with thickening of the glomerular basement membrane, IgG positive in IF, and subepithelial immune deposits in electron microscopy. Traditionally, membranous, this is not far long ago, has been classified as a primary or a secondary membranous nephropathy. And however, with the new discovery of new antigens, membranous and the discovery of new circulating antibodies, the new growing recognition have changed the classification. And this started with the turn point that happened in 2009 with the discovery of M-type phospholipase A2 receptor as a target antigen in idiopathic membranous nephropathy. In this study, they took the sera of the patients with membranous nephropathy and mixed it with the glomerular extract of normal glomuli, and they did Western blot, and they could identify the antibody as well as the target antigen. With the same method, about 5 years later, they could describe the thrombospidin type 1 domain containing 7A as another target for idiopathic membranous nephropathy. And with these discoveries, the pictures of membranous nephropathy as an autoimmune disease was put together. And when you have the antigen and you have the immune intolerance with the productions of antibodies, and then cause inflammations with the complement activations, and then you will have the clinical response with the proteinuria and nephrotic syndrome. So, PLA2R1 and THSD7A, they are the only 2 antigens that has been proven that they are pathogenic. Their function is not fully characterized. However, the PLA2R1 mediate podocyte attachment to the collagen type 4, and so this process could be disturbed by the autoantibodies, and THSD7A has stabilization role in the slit diaphragm. With that, the classifications of maybe the look for the membranous nephropathy from traditionally known as primary and secondary with the disease associations with antibodies actually. At that point of time, that it was only the 2 discovery of antigens that could be found. And with that, you can see that up to 55% of antigens are not discovered yet. So what are these potential antigens? There is another turn point in the diagnosis of membranous nephropathy, and that happened because of using another technique. Remember that the first antigens that I have described before, they use a normal glomuli. Here, what they actually use, they laser microdissect of abnormal glomuli with a patient with membranous nephropathy, and then they did a trypsin digestions, and then they did tandem mass spectrometry, and then with this method, when you extract the glomuli, So with this method, you can either describe new proteins or maybe discover new proteins. And that's what happened. And I'm going through the first antigen has been described by this method, which is oxytocin 1 and oxytocin 2, just as an example. And when they started actually with the subjects from the mentor study, and they have taken about 15 cases as a pilot study, and they found about 5 cases they identified by this method. And then they did so many tests on these just to confirm that these are truly an antigens have a pathological role in the disease. And they did, one of the tests was histochemistry staining for oxytocin 1 and oxytocin 2. And also, this is another antigen actually, which is the NIL1, which is the second antigen discovered by this method. And they did also the confocal studies. They stained the antigen and the immunoglobulin, and you can see they can match. So with that, also, some of the antigen, they managed to identify an antibodies in the serum of the patients. And they collectively, they have taken, they studied these populations, and they could find so many information about the antigens. An example is the oxytocin 1, oxytocin 2. They are predominantly female. They have autoimmune serology. They are young. So they conclude that oxytocin 1 and oxytocin 2 is associated with autoimmune disease. Interestingly, also at the point of the diagnosis, so many cases they were negative for autoimmune disease, but with time they developed an SLE. So oxytocin 1, oxytocin 2 also can have some of the markers have some of the prognosis, like oxytocin 1, oxytocin 2. They found that actually is a positive thing. Positivity of this antigen is a good thing, a good biomarker in patients with SLE, with membranous nephropathy, and you can see the difference if you have oxytocin negative or oxytocin a positive case. And then, since then, you can see this is 2009. There was a gap until they discovered the THD. A new method came up when they are targeting, looking into the abnormal glomeruli, and since then you have almost yearly publications of these antigens. And by studying all of these antigens, they could have so many clinical information about this patient. For example, the second one was NIL1. NIL1 is like heterogeneous, like in any kind of, like you could be seen on any kind of membranous nephropathy. SIMBA3B, for example, is mainly on pediatric and carry worse prognosis, tend to relapse. PCHD7, for example, is found that it is in elder patient and had a good prognosis, and usually no complement activations on the biopsy found. And FAT1, mainly in stem cell, hematopoietic stem cell transplant or kidney transplant. The latest antigen discovery was NDNF in syphilis patient and BCSK6 in non-steroidal anti-inflammatory drug use membranous nephropathy. And you can see that these antigens, they vary actually. They can vary in their circulating antibodies, if there is, they could identify in circulating antibodies or not. They vary what's the subclass of that antibody. They vary what is the clinical characteristic of the disease, and also in relation to the membrane as well. So from all of this knowledge, how we can add this to the clinical implication. Probably you can use these antigens in new classifications and look into the membranous as antigen-associated disease. Here in a review in Kidney International published recently in 2023, maybe you can start by to stain is with the most common antigens, which is PLA2 are still the most common, and the NIL1. If negative, maybe go by the history. For example, if you are dealing with a patient with autoimmune disease, maybe look for the oxytocin 1 or NICAM1. If you are dealing with a patient with syphilis, look for NDNF. If you are looking for a patient with non-steroidal anti-inflammatory drugs, look for the BCSK6. And in tumor, you look for NIL1 and THSD7A. And in pediatric, for example, maybe he is listed as less common, but however, when you are dealing with a pediatric case, this is no longer will be less common. Maybe you can list it here as maybe second common antigen, SIMBA3B in pediatric patient. I just wanted to mention also there is so many techniques tried. There is another method that they are using to identify the antigen, and one of these methods is that they do immunoprecipitate in the immune complex. And they discovered so many antigens, or you can see maybe a biomarker of a disease, or you can call it maybe it is like proteins that or antigen that overexpress in the patient membranous. They've never been able to find it is pathological or not, because with this method they used the immunoprecipitate of the immune complex. They could not identify the immunoglobulin from the glomerular extract or from the sera of the patient. So still there is so many questions mark about these antigens, and they have been listed as putative antigens. And maybe we can hear about these antigens in the future. So with that, I can conclude my first part that membranous nephropathy is no longer a single disease, and it is a pattern of injury, and perhaps in the future, already we are classifying the patient as PLA2 associated membranous nephropathy as positive or negative, and maybe in the future we will continue to classify using the antigens as the target antigens for the better classifications, and maybe you will have a better understanding, and the membranous nephropathy as known as 1/3 rule, it will not be no longer valid. How we can reflect this knowledge in clinical practice? It's the main advantage, all of the studies or all of the clinical implications come from the PLA2R1 associated membranous nephropathy, because it is the first antigen has been discovered, as well as it is the most common antigen. And antibody against this antigen can be measured in the serum by two methods, either by using indirect immunofluorescent or ELISA. Both are commercially available in most of the labs of the world. Immunofluorescent, they give you only positive or negative test, but is more sensitive. ELISA will give you more of quantitative results, and so it is important for monitoring of the disease. Since the specificity of this antibody is not found in any other kind of disease, and the specificity almost reach about 100 in meta-analysis, and sensitivity is less, about 78. So such high sensitive test, can we use it for diagnosis without going through a kidney biopsy in a patient with nephrotic syndrome? And as we know that membranous nephropathy is the most common cause of disease in adults. This hypothesis has been tested in one study. They looked into about 101 patients, and in this patient, they wanted to find out if additional kidney biopsy, all patients have positive PLA2 serology, all patients have a kidney biopsy, and they just wanted to look into the biopsy finding, if the biopsy findings will change the management plan of these patients. And none of, especially when the EGFR more than 60, the finding did not change management plan. The patients will have the same management plan regardless if the patient have gone through a kidney biopsy or not. Additional information they could find when the EGFR less than 60. Most of the additional information was mainly of acute tubular injury. Only maybe one case have acute incision nephritis, and you will by that you can say that this might change the management plan in this patient. And this have led for the first practical point in the new KDIGO guideline that a kidney biopsy is not required to confirm a diagnosis of membranous nephropathy in a patient with nephrotic syndrome and a positive anti-PLA2 antibody test. What about if you can see patients with secondary membranous and they have a positive test? How we can explain that? This may be not a true positive. They are not true secondary cases of membranous nephropathy. Maybe they happen to have the same disease, both diseases at the same time, and this has been found in a case report. They reported that the cases they entered remission without treatments, or a case they entered remissions despite they did not enter remission despite treatment of the secondary cause. Here an example of a case, and you can see here at the beginning the proteinuria and the anti-PLA with the treatment of hepatitis C positive patients. Despite treatment with hepatitis B, patient did not enter remission, and actually when they treated the patient as primary membranous nephropathy with cyclophosphamide and corticosteroid therapy, both the anti-PLA antibody and the proteinuria came down. And with this also anti-PLA 2R1 antibody, now we can look into the disease or the clinical course of the disease as immunological and clinical. Here in a review article, they have described that just to see why you have sometimes a negative test while patient is having the disease. And this can be explained by the kidney as a sink hypothesis. At the beginning of the disease, the anti-PLA is negative because the amount of productions of the antibodies are small, and all of the antibodies produced are going to the kidney and causing the disease. With time, when you have so many productions of the anti-PLA2 antibody, you will have more antibody detected in the serum and also in the tissue biopsy of the patients. And here, when you have a resolution of disease either by medications or spontaneous, you will have reductions of anti-PLA2 antibody, and you can see that the immunological response is happening earlier than the clinical response that we see in the proteinuria. So PLA into the advantage of knowing of the discovery of PLA2 antibody that can predict prognosis, clinical outcome, assess disease activity, relapse or remission. And this has been tested in so many studies, and you can see that in one study they look into the level of PLA2 in comparisons with partial, complete, or spontaneous remission, and you can see the higher the level, the less likely the patient will get into remission, and it was statistically significant. But it's still the debate, what is the cutoff value of anti-PLA2 to R, so you can classify the patient as high titer or low titer. And high titer also found that it is associated with development from non-nephrotic to a nephrotic risk factor, to the development from nephrotic to a non-nephrotic to a nephrotic range of proteinuria in the future, and correspond with the treatment, regardless what was the treatment, is CNI, alkylating agent, or rituximab. And you can see also they found so many studies that the graphs are similar. The immunological response started, and then the clinical response followed. Also, the higher the titer, the lower chance to achieve remission in the future. And also, if you have the lower titer, they will have a faster improvements in the clinical course. And PLA level is identified as a risk factor for not achieving remission. Here, also it has been associated with risk of relapse. Here, by case, we can see that this is the level of the proteinuria, and this is the anti-PLA antibody. You can see response, another response, correlate here, not much of response, both coupled by the anti-PLA titer. And here, patient responded, however, then they have a re-rise of the antiphospholipid antibodies, and followed also by a relapse of the disease as well. In also cohort study, they found also if you have either you have an increase or you have re-emerge of antiphospholipase antibodies, then you have a relapse of the disease. It is correlated with the re-rise of the titer or re-emergence of the titer with follow-up. And with that, KDIGO guideline also have add another practical point that you monitor the anti-PLA2 antibodies, anti-PLA2R antibodies at 6 months to evaluate treatment to response and to guide the future of therapy. So going back to all of these evidence, now we have the KDIGO guideline have to change their guidelines in 2021 and compared to guidelines in 2012. And in the first guidelines, the clinic, they mentioned only 2 agents, which is cyclophosphamide corticosteroid cyclotherapy as a first line and CNI as a contraindication. Here, with the more evidence about knowing about the more of advanced knowledge about the disease, and also using anti-PLA antibody as a marker for a disease, and also a marker for an outcome, they classify the patient as moderate, severe, and very high risk, and they add rituximab because there are so many studies have been done after we have completed the pictures of an autoimmune disease and use an autoimmune therapy medications in membranous nephropathy Rituximab was added, actually, it was mentioned in the first guideline, 2012. However, it was mentioned with no recommendation because there was no randomized controlled trials at that point. So, since that discovery of antiphospholipase antibodies and so many other antigens, there has been during this period, there was so many trials, mainly testing the efficacy of rituximab. And here showing the areas of these studies over time. And one of them is the I will start with the Germatics study that was published in 2017. They compared the standard therapy to rituximab, and rituximab was better even at 18 months of follow-up, and also there is a reduction in the biomarker of antiphospholipase antibody. And then the Mentor study, they compared the statin therapy and, CNI, the cyclosporine, and the 2 doses of rituximab. Also, they concluded that rituximab is superior to CNI in maintaining remission.
1 minute.
And rituximab also have been, and then the other 2 studies, they compared the first-line therapy, cyclosporine and corticosteroid with rituximab. And this is in a pilot study. They found there is no signal of superiority of one therapy over the other. In Starman trial, which is bigger randomized controlled trial in Spain, and they compared the cyclophosphamide and corticosteroid, the first-line agents, in 2012 guidelines with rituximab. And they've actually found that the rituximab is not superior, actually it's inferior. However, there was some limitation of Starman trial that they use a lower dose of rituximab, about 1 gram, compared with other studies they use about 1 to 3 grams. And the anti-PLA antibody in the rituximab group, it was at twice at level in the cyclosporine and corticosteroid. So what's the dosing protocol in optimal rituximab in membranous nephropathy? Here, the NICE cohort, they compare most of the centers, they use about 1 gram 2 weeks apart. With the Gemrix cohort, they use about 375 milligram 2 doses, and they found it's superior in times of remission, time to remissions, and depletion of B cells, and the level of rituximab in the serum. So, in the summary of the studies, that rituximab is better to standard care, better than cyclosporine, CNI. It is as good as cyclophosphamide and corticosteroid. With this, you have more options about treatment. So maybe you need to balance again the risk of immunosuppressions as well as the risk of a response and prevention of the kidney disease. And hence, the clinical guideline have with the new guideline, they have new classifications, and they have used so many information to classify the patients, and one of them is the anti-PLA2 antibodies. More than 50 will classify the patient as high risk, so it's very important to test for this antibody prior to start the treatment. And also they have used anti-PLA as monitor as well in the guidelines. If it's absent, you can stop and taper, decrease, continue, and like in a lower doses, high, maybe switch to other agents. So with that, my summary to the talk for today, that discovery of the new antigens in membranous nephropathy shows that membranous is heterogeneous disease, and maybe the 1/3 rule no longer will be valid in membranous nephropathy in the future. In the era of personalized medicine, it's critical to understand, characterize each of these antigens, and you can be able to implement these antigens in real practice in the patient in terms of prognosis, outcome, and respond to treatment and treatment selection. Alkylating agent is still cyclophosphamide, is the only agent studies in trial that evaluate the clinical outcomes as such all-cause mortality and kidney failure. Randomized control trials, including the rituximab and cyclosporine and CNI, is only evaluating the remissions and side effects.
Thank you, Dr. Shaima, for this excellent update of the topic. And we'll proceed with the next speaker.
Yeah, our next speaker is Dr. Hamad Jilani. He's a consultant nephrologist, senior specialist nephrologist.